And she said, well, Ronnie, should I, that's what she calls me, Ronnie, should I go into the study? I get a free chest x-ray every year. And I said, well, Mom, what if they put you in the arm where you don't get a chest x-ray? She said, well, can't Dr. Bushman just order it on me anyway? And that's the crux of why this study is not so great, is because there is a lot of crossover and contamination in the arms of the study. First of all, with the study, there was an incredibly low death rate in both groups, and only a 7-year follow-up, which this has been beaten into us for a long time now. We know that 7-year follow-up is far too little when death from prostate cancer is the endpoint. That's a very, very short follow-up time. And there's also considerable contamination in both arms of the study. 38% of the non-screened group were screened with PSA testing, and that's those that admitted it. There have to be some people who had continued to get PSA screening that just wasn't on the radar of the investigators. And in addition, 15% of those who were supposed to be getting screened did not. I'll read this to you. I don't know if you can see it in the back, but in the actual study itself, in the discussion section in the published study, there were 4 big criticisms showing that this study might not be so perfect. And here they go. There are several possible explanations for the lack of reduction in mortality so far in this trial. First, annual screening with PSA test using the standard cutoff of 4 nanograms and digital rectal exam to trigger diagnostic evaluation may not be effective. And we know ourselves that a strict cutoff is not what we use in everyday practice in urology. We consider it almost an art where you combine the patient's demographics, their risk factors, their PSA density, velocity, age-related PSA, racial predilection, and all of that goes into our thought process. So a 4 milligram cutoff is certainly not, doesn't reflect everyday life. Second, the level of screening in the control group could have been substantial enough to dilute any modest effect of annual screening in the screening group. And that is certainly true. Third, approximately 44% of the men in each study group had undergone 1 or more PSA tests at baseline. So that's almost half of the patients that enrolled in the study in both arms already had a PSA test. So you've already gotten rid of the prevalence for the most part, and now you're relying just on incidence alone to prove a difference, and then further to prove a difference in survival secondary to prostate cancer. So that's a lot to that's a big leap of faith to base anything on this, to base any policy changes on this study. Fourth, and most potentially important, improvement in therapy for prostate cancer. And keep in mind the therapy wouldn't have been possible without the screening and detection of the prostate cancer. During the course of the trial, probably resulted in fewer prostate cancer deaths in the 2 study groups, which blunted any potential benefits of screening. So the study has been trashed, and what do? We take the ball and run with it. So the task force recommended no screening at all. The American College of Physicians recommends very limited use of PSA, saying that it does more harm than good. And the American Academy of Family Practice goes even further, saying PSA is of no use at all in any group. Even our own AUA, which Dr. Carter will talk about, I'm sure, tomorrow in the same time segment, even our own AUA recommends a very limited use of PSA, mostly based on this study. Finally, we're going to get back to kidney cancer, which is what we were supposed to talk about in the first place. And this is an article that just came out a couple of years ago, and for some reason, I guess because it's randomized and prospective, generated a lot of splash, especially at the SUO meetings, in the cancer sections of the AUA and at ASCO. It's a prospective European study looking at outcomes in partial nephrectomy versus radical nephrectomy. And they showed, this is a randomized prospective study, better overall survival in radical nephrectomy than partial nephrectomy, which took everybody by surprise because there's no great reason why this should occur. But it did generate a lot of controversy since all previous studies showed exactly the opposite. But since this study is prospective and randomized, level 1 data, of course my residents started questioning my widespread use of partial nephrectomy. But in this study, there were only 541 patients enrolled over a 20-year period, and the target was actually 1,200 to 1,300, so it really didn't meet their enrollment criteria. There were very, very few recurrences and deaths from kidney cancer, and the follow-up was 9.3 years. And what they showed, though, is that the overall survival was actually better for radical nephrectomy in the intention to treat analysis, the 81% versus 61%, showing a statistical superiority of radical nephrectomy. In the targeted patient population, patients who actually had renal cell carcinoma on final pathology, though, there was really no difference in overall survival. So keep in mind that the level 1 data is based, according to the task force guidelines, level 1 data is considered to be based on properly designed prospective randomized studies, but there is no guarantee that the study is properly carried out. So this study, I'm not saying that people were negligent or that the investigators, obviously they knew what they're doing, but they had a very difficult time recruiting patients, and as a result, the study suffered. This study refutes many prior studies, so that should be a red flag to everyone. It disregards common sense, and at most, it may lead to an increase in radical nephrectomy in patients among doctors who don't like to do partial nephrectomies, and with it, we might see an increase in chronic kidney disease, chronic kidney failure. Fortunately, a year later, a group from Michigan published this study. Now, of course, it's not randomized and prospective, but this is a retrospective study looking at the SEER and Medicare database. And they looked at 7,000 patients over a 15-year period that underwent surgery for suspected kidney cancer in early stages. These were all tumors that were under 5 centimeters. And they showed, oh, I'm sorry, these were all T1 tumors. T1A tumors. And the there were 5,200 radical nephrectomies, close to 2,000 partial nephrectomies with a 5-year follow-up, and they showed, as expected, no difference in the cancer-specific survival, and the overall survival in partial nephrectomy was better than radical nephrectomy. And this just shows the same thing in, I just said, in graphic form. This is a kidney cancer mortality. This is disease-specific mortality was higher in radical nephrectomy. And since this wasn't a randomized study, you'd sort of expect that anyway, because these are going to be, even though they're all T1A tumors, these are going to probably tend to be a little bit larger. So there's a difference. The partial nephrectomy did better. More people died. This is the percentage of people dying from kidney cancer is higher with radical nephrectomy than partial nephrectomy. And all-cause mortality, again, this is death up here. More people died over a 10-year period from all causes following radical nephrectomy versus partial nephrectomy. So I'm done beating up on evidence-based medicine. I'd like to now talk about partial nephrectomy, finally. No more MAPS, no more evidence-based medicine. Over the past many decades, the margins have decreased, as we know, in doing a partial nephrectomy from 1 to 2 centimeters to 5 and then 1 millimeter. And it's basically accepted now, widely accepted, that as long as you get a negative margin, the size of the margin really doesn't matter. Renal tumors, unlike prostate cancer, breast cancer, other types of tumors, as we all know, small renal masses are discrete and well circumcised. They don't typically have little tentacles that go out into the normal tissue. And once you excise the tumor, the crater is very easy to assess, even with a naked eye, but especially if you have a good pair of loupes on, you can see if there's any residual tumor in that crater if you're just honest with yourself. You also, if you look at the specimen after you remove it and see what the cut edge looks like, make sure there's no violated tumor. You may actually see tumor at the edge, but as long as it's not violated, you can be pretty sure, or you can be certain that you got it all out. It is impossible to get parenchymal coverage over tumor areas that are adjacent to the sinus fat, capsular fat, collecting system, and larger vessels. And this shows just that. So here's a typical tumor that's fairly deep. If you have any deep tumor that abuts sinus fat, collecting system, even urine, you're not going to be able to get a negative margin. The pathologist is going to see tumor at that margin no matter what, but it certainly doesn't mean that you've left cancer behind. Now, in the parenchymal area here, you're going to be able to get a small rim of normal tissue around the tumor. And that leads us to another topic, is frozen section analysis actually necessary? In this study from Israel, they looked at 300 partial nephrectomies, and they were done with frozen sections, and only 2 of those had positive margins on frozen section. They found no they went back at the same time, since they had a positive margin on a frozen section, they took out both of those kidneys and found no residual tumor. The corollary to that is that they had 4 who had negative margins on frozen section, but on final pathologic review, they found that these patients did have a positive margin. And of those, 3, they didn't operate on them immediately. 3 remained NED, and only 1 had a clinical recurrence and subsequently underwent radical nephrectomy. So frozen sections have, I don't want to say have gone by the wayside, but they almost have. I certainly don't employ them routinely in my practice, and I think most people do not anymore. This is a typical patient of mine, and I'm sure a lot of yours. Nice big belly there. This is a CT scan, and when he comes in, he says, "Oh, look, I'm big, but you can't pinch an inch." And of course you can't, because all the fat is on the inside. It's all visceral fat. Metabolic syndrome goes along with this, and you know this fat around this kidney is that toxic fat, that hemorrhagic indurated fat that you hate. And you can't get to the tumor, and it's really a miserable operating experience for everyone, and very little fat on the outside. But even with a patient like this, you can still operate on this and have a nice result once you get exposure. So this is a little video of my taking a resident through a partial nephrectomy in a patient just like that, small renal mass. This is me here and the resident over here. This is his very first partial nephrectomy that he's ever done. And one thing that's really nice about open surgery is that the resident gets to do the operation. He's seen a few of them. He gets to actually do it. He's not sitting there with a sucker while I'm at the monitor, while I'm at the console, and he's not at the console while I'm having a heart attack watching him. We actually get to do this together. And just a real nice way to enucleate the tumor with negative margins, and that's that for small renal tumors. And this particular one did not require any hilar clamping. It just oversewed some small bleeders that were there at the end. Once all is said and done, we put a little piece of fat in the crater there and close the capsule over the defect with little interrupted Teflon pledgeted horizontal mattress sutures here. And the risk, if you close it this way, the risk of delayed bleeding is practically zero. We published our results using no hilar control in the Canadian Journal of Urology. You know, NEJM, JAMA, Canadian Journal of Urology. You know, they're all. Anyway, there were 105 patients that we looked at who we operated on without any hilar clamping, did partial nephrectomies. 3/4 of those were elective, 1/4 were imperative. The blood loss really wasn't as big as you might think without clamping the hilum, 400 cc's versus 800 for the imperative group. Warm ischemia time, of course, is 0. Positive margin rate, 5%, 11% for the imperative group, but no local recurrence at 5 years plus follow-up. And there's no change in the creatinine, at serum creatinine at 1 month, and at greater than 48 months at 4 years. This is an unpublished segment of all partial nephrectomies, not just the ones without hilar clamping. And this is over a more recent 3-year period with 190 elective partials at our center out of a total of over 1,000. We just looked at this tiny subset. Follow-up was greater than 5 years, which is why we picked this group. Estimated blood loss was still very low, 483 cc's, very little transfusion requirement. Warm ischemia time in all elective partials was only 3 minutes with a mean of 3.7. Only one patient had a 21-minute warm ischemia time, and the great majority of these were under 10 minutes. Positive margin rate, 10%, local recurrence rate, 0. And really any center that does a lot of these has very similar, if not better, results with local recurrence rates. Really should be 0 or close to 0%, and that's how it is at all of these centers here. And the 5-year disease-specific survival rate should also be very, very good. So how do you improve on these excellent results in open partial nephrectomy? It seems like we can't really go anywhere else. And one way to do it is the robotic partial nephrectomy. Just think of it. No incision, quicker convalescence, less blood loss. But there's a problem. If you do a straight laparoscopic partial nephrectomy, you can't get this same angle at enucleating the tumor. So this is what you get in an open procedure, where you can cut down in this direction and then bring your dissection plane horizontally. But with the straight laparoscopic instruments, that is really, really difficult to get this downward angle. And quite often, you run the risk of violating the tumor itself. Now, the robot can get around that because, of course, it has the same angulation and ability to do what your hands can do. But what it doesn't have, of course, is tactile feedback. So if you have, and you've all been in that situation, where you have a very soft tumor with a lot of necrosis, and you just look at the thing and it's ready to pop and spill necrotic tumor all over the place. And this is an unfortunate example of a patient who underwent a straight laparoscopic partial nephrectomy years ago. And this patient had a 2-centimeter clear cell carcinoma, obviously had some tumor spillage at the time of surgery, and these are all little satellite deposits of metastatic disease or spilled tumor that have since grown within Gerota's fascia. Now, keep in mind, if you do this as an open procedure, and I will definitely be the first to admit that I violate tumors all the time. But if you do it when you're doing it as an open procedure, you can contain it. We have powerful suction. We can pack the kidney off. You can clean up the mess that you've made and keep that patient from having any trouble. In this case, if you do it with a minimally invasive approach, you simply can't do that. And so this patient went on to get a radical nephrectomy and then subsequently died of metastatic kidney cancer, all for a 2-centimeter clear cell carcinoma. So how do you avoid this tumor violation and tumor spillage? Well, one way to do it, if you're doing a robotic partial, is getting wider margins. And I certainly will admit that if I'm doing a robotic, I definitely take wider margins just because I'm terrified of cutting into the tumor. So wider margins, and with wider margins comes a longer warm ischemia time. And this is not one of my patients. This is a patient that was in the next video that I'm going to show you. These are the patients that are always selected for these videos. This is a nice skinny lady. And this is her nice skinny lady CT scan. It shows no fat around her kidney at all. Nice little tumor here. You could probably do this open in about an hour with no warm ischemia time. But here is a video that was shown at the AUA last year. Now keep in mind, this is, and I don't mean to badmouth this person at all, this is a very, very good surgeon. But he's doing what is needed to be done when you're doing a robotic approach. This is an excellent surgeon from a very big center with a lot of experience, and this was a live video taping of his doing this partial nephrectomy robotically. And you'll note here some insanely large margins. Some of these margins here I think are arguably like 3 or 4 centimeters. And when he's enucleating this tumor, he's cutting into vessels that are very, very large branch vessels going to not only to that tumor, but you can't tell me that big vessel there is just feeding that tumor. It's definitely feeding some normal parenchyma as well. And there's no doubt that this patient is being clamped at the time. The hilum is clamped or they'd be bleeding to death with vessels this big showing. So the total warm ischemia time for this operation, for a tumor that's not enormous, was 19 minutes. And everybody's high-fiving, 19 minutes, hey, that's so great, what an achievement. But if you really think of what you're gaining for this is just the lack of an incision, you're giving up a lot in return. So a long warm ischemia time is not to be taken too lightly, as I'll show you soon. The other thing is that when you have the patient on clamp like that, you sort of have to work frantically to get everything oversewn. It's not the nice relaxed pace where you can sit there and enjoy teaching your residents, and the resident basically is just sucking like crazy so that you can stitch everything up and get the patient's clamp off the hilum. So at the end of that case, the surgeon was interviewed, and he was very pleased with the 19-minute warm ischemia time, and that for that kind of a big defect, I thought that was pretty impressive. But oftentimes, especially in lesser skilled hands, the warm ischemia time goes considerably longer than 19 minutes. And the question you ask then is it damaging? There are a lot of studies showing that there's no real change in the creatinine level in elective partial nephrectomies, even with long warm ischemia times, but that always has to be taken with a grain of salt because the creatinine level can do anything. When you take a person's kidney out, I've seen that, I'm sure you have too, you do a total nephrectomy on one side, and the creatinine goes from 1.3 to 1.2 the next day. You wonder, how did that happen? So the creatinine is highly variable and not the only, it certainly should not be your only indicator as to whether or not you've caused any damage to the operated kidney. Anyway, this is a paper from European Urology, an Italian group. They said, is renal warm ischemia over 30 minutes possible? I don't think they meant possible. I think their translator should have probably put, safe or effective. Certainly it's possible. You can keep the clamp on for 3 days if you want. And they show that what they actually did with this and the subsequent study I'll show you is they did scintigraphy. They did MAG3 studies so that they could really correlate the operated side with the non-operated side. And they showed that with longer warm ischemia times, 30, 40, 50 minutes, there was a definite reduction in the contribution of the operated kidney that persisted. And this is another study from Japan, also published in European Urology a few years ago, that showed that the title was Ischemic Renal Damage After Nephron-Sparing Surgery in Patients with a Normal Contralateral Kidney. And they did the same thing with the MAG3 studies, and they showed that if they used various cutoffs, but the one they finally arrived at was a 25-minute cutoff for warm ischemia time. If the patient was clamped for less than 25 minutes, they had a reduction. This is the operated kidney, and this is total function. The percent reduction was significant, but then returned nearly to baseline at 6 months. So they repeated these scans at 1 week and 6 months. And if the clamp time was greater than or equal to 25 minutes, it was reduced to 2/3, not even 2/3 of the original function, and it never quite rebounded. So you had significant damage after 25 minutes to the operated kidney. So how do you get around that? So because this is a big issue, we don't want to keep people with an ischemic kidney for very long. So this has been introduced, the zero ischemia laparoscopic robotic partial nephrectomy. And what essentially it is microdissection of the smaller branches of the renal artery supplying the tumor, the one that you suspect supplies the tumor. If you're fortunate enough to have the Firefly at your institution, you can use that to make sure as well. But sometimes you can just see by clamping the little artery whether the kidney turns blue, and to see if that's exactly the artery, the smaller artery that's supplying your tumor. There are some problems with this. One is that the smallest branch you can dissect is the first order of branches. Where the main renal artery comes off, you have 5 branches. To think that you're going to get secondary or tertiary renal arterial branches is impossible, because those are all inside the kidney. So after you've dissected out one of the 5 branches that you think is supplying that segment where the tumor sits, you then put a little micro bulldog on that, and you clamp it, and theoretically this allows for normal perfusion of the rest of the kidney through the other 4 arteries during the partial and the excision of the tumor, and it should be in a bloodless field. One problem, though, is that it's not really in a bloodless field, because the vein cannot be clamped. Even though the arteries are end arteries, the veins are not. So you get an awful lot of, and you still have the other arteries open, so you're getting a ton of venous inflow from the collaterals, so you're still getting a tremendous amount of venous bleeding. So what do you do about that? This has actually been proposed, believe it or not. Many centers now supplement this with globally induced hypotension. So you decrease the patient's blood pressure completely, so that there's even less perfusion through the other arteries that are bringing in all the venous blood. And that just seems like a totally bad situation to me. So not only decreasing the perfusion to the kidney that you're operating on, but you're reducing the perfusion of the other kidney, the good kidney. And it also it goes with it increased risk, theoretically, of stroke, heart attack, and other complications from hypotension. So I think that's a totally bad idea. The section of the hilum is risky and impossible in obese patients, like that metabolic syndrome guy I showed you with the toxic fat. If you think you're going to dissect out the little tiny branches of that guy's arteries in his hilum, you are an amazing surgeon, I can tell you that. Visibility with the robot is also touted as being such a great thing. And again, I don't mean to badmouth the robot. It's something that I do and I enjoy. But when I hear the reps and others saying that the visibility is superior to everything, it's not to be believed. It is certainly superior to the monocular vision you get with standard laparoscopy, no question about it. But it is not as good as a good pair of loupes. You get stereoscopic vision with both. The vision is definitely sharper with much smaller objects with loupes than it is with the robot. Loupes cost $1,600 with a prescription in them. The robot costs 1,000 times more. But nevertheless, robotic partials are definitely here to stay. Recent analysis using the SEER database, looking at 38,000 partial nephrectomies done in a 3-year period by the group from Henry Ford in Detroit, shows an increase in robotic partials by 45% in that time period. There was a similar increase in open and laparoscopic partials, but nowhere near as much as the increase in robotics. And they also noted that the cost of the robotic partial nephrectomy is 35% higher, and that's something that may have an impact in the future. Before ending this, I wanted to give a brief shout out to this ancient technique. This is sort of a technique, a posterior lumbotomy incision has kind of gone the way of nephropexy. This is an incision we used very rarely when I was a resident. We used to use this to gain access to the kidney for open renal biopsy in patients who were like coagulopathic and that sort of thing. And it's an incision that goes through the skin and fat, so that's basically painless. And then you go between the erector spinae and quadratus muscles and the lateral musculature of the abdomen, and it drops you right down onto the kidney. And but if you're going to use this for kidney tumors, it has to be a posterior tumor. It has to be a lower pole tumor, because if it's an anterior tumor, obviously you're not going to get to it. If it's a mid or upper pole tumor, the 12th rib is going to be very much in your way. In addition, you cannot get hilar access. So if you have a big, deep tumor and you think you're going to have to clamp, forget this incision, please. But we started resurrecting this because there was a patient who came in with really, really weird vascular anatomy. He had complete occlusion of his aorta, and he had huge collaterals that were supplying his legs. And we didn't want to go through the front, we didn't want to go through the flank because there were vessels that would have potentially compromised the blood flow. So he said, oh, what the heck, let's try the posterior lumbotomy. And despite this fella being, fairly ill, the results were amazing. I couldn't believe he left the hospital on post-op day 2 for a guy who you'd normally expect to be in the hospital for a month. So, because the pain is really non-existent, and the results as far as recovery and that sort of thing are the same as with a robot without the cost of the robot. So I've done this in a few patients over the past year. This is how you do it, the little posterior lumbar. You place the patient in a prone position. This is their buttocks here, heads up this way, obviously. This is the midline, this mark right here. This is the 12th rib, iliac crest, and there's the incision, kind of a near vertical incision right along the path of the border of the erector spinae muscle. We've done 15 of these over the past year, 10 women, 5 men. Tumors have ranged from 1.2 to 3 centimeters, so very small tumors, very selected group, 2 centimeters average. 9 of these were malignant, 6 were benign. The OR time is very quick. There's nothing to open, there's nothing to close, a little tiny bit of lumbodorsal fascia, and then drops you right down onto the kidney. And there's the tumor right there. You enucleate that. Of course, the warm ischemia time is 0. You have no choice because you can't get to the hilum. And the length of stay was comparable to any robotic series. Most patients, the great majority, gone home after 1 or 3 nights hospitalized. So the future of partial nephrectomy, I hope, is bright. We've seen a steady increase in all stages of renal cell carcinoma because, again, probably because of obesity and aging, who knows. With less money being available for health care, we'll have to see. The great majority of patients that I get referred for partial nephrectomy are those who had their tumors discovered incidentally when they underwent CT or MRI or ultrasound scanning because they had vague abdominal pain or a little bit of nausea or whatever. So with less money available for each individual patient with healthcare dollars, we may see a decline in these CYA studies. Like radical prostatectomy, decreased detection may lead to a decreased number of surgical cases. We've seen an increase in renal cell carcinoma and small renal masses, and this has been a true opportunity for urologists over the past couple of decades. Partial nephrectomy continues to increase, but hopefully that we won't see a decline in that. It'd be nice to see a decline in the overall disease process, but I certainly prefer doing partials with small tumors in patients you can cure rather than big radicals where you see a lot of death from renal cell carcinoma. The implementation of technological advances should not be driven by marketing, but rather by a true benefit to the patients. And finally, don't feel bad about being a dinosaur. Newer isn't always better. Thanks from Pittsburgh, and thanks from the duck.
Anybody have any questions?
Anybody wants to yell at me? Oh, here comes somebody yell at me. Okay.
That was a great talk. Jay Rahman from Hershey. So I guess my question for you is, do you think that postoperative kidney function is more a function of ischemia time, or do you think it's a function of the volume of kidney or preserved renal parenchyma? A lot of the techniques you were showing, you had low warm ischemia time, but you also advocated enucleating the tumors, which therefore leaves you a large degree of functional renal parenchyma. And I guess I would argue I would be less worried about clamping and getting a bloodless field if I could do a good enucleation or a good resection without cutting into the tumor, because I would maybe contend that's the more important variable than if your ischemia time is 0 minutes, 5 minutes, 10, or even 15 or 20.
Yeah, that's a great question. That should be studied in the lab. I don't think there's an answer to it, but that's an excellent question because those are definitely big factors.
Thank you very much for the topic. I'm Kellen Choi from Charleston. Speaking of ischemia time, do you in your institution use mannitol routinely?
Yes.
And if so, do you think it really definitely affects the ischemia time, especially if there's so short ischemia time with the small renal mass?
I don't think it affects the ischemia time, but I think it affects the overall function.
function,
Yeah,
right.
yeah. I think that's has been shown on a molecular level. Prevents edema of the tubular cells, and there have been some clinical studies that show that mannitol is effective as well.
I guess
And so we
my-
usually give 25 grams for normal-sized
Right.
people, 12.5 for really small people.
Our institution uses it routinely too, and I believe it too, definitely for that pathophys. But I was just curious because with finding such small renal cell nowadays with the incidental loma and warm ischemia time being so short, I was just wondering if you still believe that mannitol use will be.
It might be a waste of time, but sometimes you don't really know what you're. I even give it when we're not planning on clamping at all because you really don't know. I mean,
Right.
sometimes you nucleate the tumor, you'll find a huge bleeder, and all of a sudden your operative field is filled with blood, and you have to clamp. And so it's nice to have had that given ahead of time.
Thank you, sir.